Hello, everybody, and welcome to the ninth webinar of the global platform on older people and coronavirus in low and middle income countries. About a month ago, we had a really good webinar which focused specifically on these issues in Latin America. And because that was so successful, we thought it would be very interesting to have another regional webinar. And so today we're focusing on Africa, not just sub-Saharan Africa, but the whole of the African region. Next slide, please, Lucas. And as we always do in these webinars, we'll be focusing on a number of different countries. And I try to provide a little bit of information about the status of the pandemic in these different parts of the world. And certainly in Africa, we can see a lot of diversity, both in terms of the numbers of cases. So quite high numbers of cases reported in Egypt and in South Africa, rapidly rising numbers of deaths, and older people accounting for more than half of those deaths. And so the pandemic is slowly scaling up in those parts of the world. And perhaps that progression has been slower than some people were anticipating back in March. But the much more surprising trend, as I'm sure you're aware of, has been the small numbers of confirmed cases in most of sub-Saharan Africa. And here you can see for Tanzania and Uganda, almost no deaths. And that clearly has been a large surprise, and people are trying to understand the reasons for that. Some people have claimed that it was because African governments responded very robustly early on in the pandemic, and that perhaps countries such as the United Kingdom could learn from those experiences. There may be some truth in that, but it's interesting just to contrast Tanzania and Uganda. My understanding is that Tanzania never really imposed a lockdown very rigorously, and the large majority of the population, I was just talking to Sarah from Tanzania, didn't really follow the requirements of the lockdown. And that lockdown anyway was discontinued a month ago, and yet we don't see any significant change. Tanzania is yet to report a single case of coronavirus death. Now, that might be because of underreporting, but again, anecdotally, there don't seem to be significant numbers of cases or deaths. And that, in a way, calls into question this whole idea about the need to have lockdowns, particularly in very poor countries. And as we're going to see today, of course, those have had very large effects on older people and more generally. Next slide, please, Lucas. A couple of weeks ago, The Lancet had an editorial about coronavirus in Africa entitled "No Room for Complacency." And in a way, that's very much reflected by a piece that came out today in The Guardian reporting on WHO, which is concerned about accelerating rates of coronavirus infection in Africa. And, you know, the Lancet paper again talks about sub-Saharan Africa as a surprising case, an enigma. It talks about some of the indirect consequences of lockdown, and it's particularly concerned about the effects that coronavirus may be having in terms of crowding out concerns about other health issues in sub-Saharan Africa. And it refers very specifically to immunization programs and interventions to improve child health outcomes. The Guardian report talks about the risks of pushing millions of children into child labor and into poverty. And of course, those are all genuine concerns. None of this coverage whatsoever makes any reference at all to older people. And there is a view in both of those that one of the reasons why sub-Saharan Africa particularly has been less affected by coronavirus is because there aren't so many old people living there. Next slide, please. The numbers say something rather different. If you look at the total number of people aged over 60 in the I should have put this on the slide, sorry, in the USA and Canada combined, 85 million. Africa, 74 million, not much less. think about the amount of policy and research and general attention given to those 85 million older people living in North America, and compare that to the attention that those 74 million older people get in the continent of Africa. In terms of the percentage of Africa's population, that may be quite a small share, but older people account for a very disproportionate share of illness and death, premature mortality in the region. So if you take the main measurements of illness and death in Africa and in other parts of the world, disability adjusted life years, older people account for about 1 in 8 of those. Recent research that I was involved with in Ghana showed that nearly 1 out of every 5 visits to an outpatient clinic there involved a person aged 60 years or more. So older people are making quite a lot of use of health services. And I published this paper in Social Science and Medicine. It came out a couple of months ago. And of course, it was one of those papers that was written last year and therefore makes absolutely no reference to coronavirus. So it feels very dated. But one of the points it made was that there's very little research about the health of older people and interventions to improve the health of older people in sub-Saharan Africa. And this remains a very low priority, both for academics and for policymakers. And I think we're seeing that to some degree still being reflected in terms of research and policy focus related to coronavirus in the region. And this, of course, relates to wider issues of ageism and the marginalization of older people in global health discourses. So I think hopefully these are some of the issues that we'll have an opportunity to talk about in today's webinar. I'm going to, next slide please, Lucas. For those of you, oh, there we go. I thought I put the numbers in there somewhere. There you go. So that's just repeating what I was talking about before in terms of the actual numbers of people aged over 60. And of course, one could argue that later life begins much earlier in terms of people's chronological age in poor countries and in rich countries, and that people over 60 are much more likely to experience disability, chronic comorbidities, and functional limitations. Next slide, please. But just moving on smoothly, just for those of you who haven't been, haven't participated in one of our webinars before, we have a way of doing things, which is I'm about to hand over now to our guest chair for this weekly webinar, who will then introduce our speakers. They will each give a short talk, and then after that, our guest chair will moderate about half an hour or so of discussion and questions and answers. So Lucas, can you just explain, sorry, before we introduce our guest chair, Lucas, can you just explain to people how they can send you their questions, either via YouTube or via Zoom?
Hello, thank you, Peter. Every participant can ask a question in the Q&A session, or also can do it on the chat with Alt H. Also, you can access the chat in the Zoom, and we are live streaming in Corona Older, so you can also ask questions in there too. Okay.
Thanks, Lucas. And yes, Lucas will be compiling some of those questions and passing them on to our guest chair and moderator, who is Professor Max Bachmann, who is based in the Norwich Medical School in the University of East Anglia. He's also got honorary positions in a number of other universities in South Africa and other parts of the region. And I think, you know, he has a very relevant background to help us think through some of these issues. He's trained as a doctor, as a clinical doctor. He's worked for many years as an epidemiologist. He doesn't just analyze data, he's very engaged with policy issues, with a particular focus on primary healthcare and trying to make things work better, translate research into better practice on the ground. And I found this on Max's website, and I think it really tells you a lot about Max and his approach, that he was very influenced as a junior doctor in the 1980s in South Africa by the struggle for liberation from apartheid. And as apartheid receded, he became increasingly focused on the needs to strengthen the role of the state in primary healthcare. And I think what this shows is that Max is very aware that health is a very political issue. And I think many of the issues that we'll be talking about in today's session will relate to the politics and the political economy of health and older people in Africa. That's politics with a big P, as well as politics with a small p. So it's fantastic to have Max with us, chairing today's session and doing the moderation. Without further ado, I'm going to hand over to Max. Thank you, Max.
Thanks, Peter. So let's get started straight away. I won't say anything now. I'll have a few comments later before we take questions. So Lucas, could we have the list of speakers? So I'd like to introduce our speakers for today. First of all, the first speaker will be Ben Jones from the University of East Anglia, who will also be speaking on behalf of his colleagues Stella Aguti and Mbali Uganda, who couldn't join us. Stella couldn't join us today because she doesn't have access to internet. Speaking about coping with lockdown, older people and COVID in Uganda. Ben will be followed by Sarah Edgar, who works for Save Elders Tanzania, speaking about the role of NGOs in protecting older people during the COVID-19 pandemic. And then next will be Wala Talat from Ain Shams University in Egypt, speaking about older people, social protection, and COVID in Egypt. So covering 3 areas of East Africa and North Africa. Unfortunately, our speaker from West Africa couldn't join us today because he's been ill. So we won't say anything more about that. And let's go straight into Ben.
Oh, thank you very much, Max. And thanks also to Peter and Lucas for giving me this opportunity to give a very brief presentation. I should, as a bit of background, say that both Stella and myself are not public health experts. We're social scientists who work on issues of, from an anthropological perspective, look at issues of social change in Eastern Uganda. But we thought we would sort of come along with a few ideas. I think that's the final slide, Lucas. So if you could put the first slide up, that would be great. So we will talk briefly about, in this presentation, about some observations from Uganda. And it very much follows on from, I think, what Peter was saying about the way politics, old age, and health intersect with each other. I mean, that's sort of the way COVID-19 exists in Uganda at the moment. Hopefully when Sarah comes along after me, she will have something to say about Tanzanian truck drivers, who are the main topic of conversation of COVID-19 in Uganda at the moment, and in terms of its spread and distribution. Lucas, if you could move to the second slide, that would be great. So as Peter was saying right at the outset, Uganda has effected one of the most severe lockdowns in Africa, and that's produced, or well, we can debate that, but it looks to have produced some of the best COVID-19 data for any country. So the current figures are 679 cases, 161 recovered and 0 deaths. And it's perhaps important to note in the case of Uganda that Uganda is coming to COVID-19 with past experience in terms of dealing with Ebola and cholera epidemics. So systems of track and trace, the Ministry of Disaster Preparedness, there's a whole institutional infrastructure, but also a public infrastructure in Uganda that is perhaps somewhat different to other contexts in thinking about COVID-19. What Ugandans would often talk about is the severity of the lockdown, though. So on March the 18th, I think when at that point there were no reported cases in Uganda whatsoever, all public gatherings, including places of worship, weddings, music shows, rallies, cultural meetings, they were all suspended. And this was quickly followed up with all school children being sent home, universities being closed, seminaries being closed, and government offices are mostly closed. In an economic sense, what also dominates debates in Uganda was the suspension of public transport. So at one point in Uganda, the only vehicles you would pretty much see on the street, whatever the regulations were, the only vehicles you would see on the street would be military vehicles and hospital vehicles. And for an economy that is sort of 80% informal economy, where urban centers rely enormously on motorbike taxis, on what are called matatus, small minibuses that get people from A to B, this was extraordinarily sort of disruptive to the economy, to rural-urban linkages, and perhaps severely felt in the capital city, Kampala. And on March the 30th, there was a nationwide curfew. In recent weeks, there has been a gradual relaxation of measures, particularly in relation to the measures that are seen to affect the economy. So that's public transport has been restored, but the schools are still closed in Uganda with no sign yet that they will be open. Cases are beginning to rise, and they're also beginning to rise away from border areas. And the impression I get talking to colleagues working in Uganda is that this is relatively reliable data. I'd be interested to hear what Sarah has to say about data in Tanzania, where it certainly from a Ugandan perspective seemed to be dealing with much sort of in the public domain, at least, higher prevalences of COVID-19, whatever the official data. If we could move to the next slide, Lucas. So the photograph at the top is, so a couple of things to say about Uganda. Uganda has had the same president since 1986. So in terms of aging dynamics, the president himself has done rather well. And as you can see there, has remained relatively healthy, has also played with his date of birth to extend his time in office. But this was an image in the Ugandan media that was sort of taken to task because it was the president saying that for Ugandans, being confined inside during the curfew, during the lockdown was viable. Obviously, this is a president in State House with an enormous amount of room within which to maneuver, from which he chooses to do his press-ups. Yeah, so there are already ideas of inequality you can see on that slide. But what's been quite interesting about COVID-19 for Ugandans, who you have to remember are dealing with really the dynamics of the politics of lockdown more than they're dealing with the health effects of coronavirus itself. Some of the dynamics that people talk about are rural-urban dynamics. So as is the case across sub-Saharan Africa, and I suppose everywhere else in the world, the state is most present in urban centers. So it's in urban centers that the lockdown has been most severe. Yeah, so the enforcement has been strongest in cities and in provincial towns, and there has been a desire amongst many Ugandans, old and young, to try to go back to the village, to try to go back to the countryside if they can, where the state is less present, where measures are more relaxed, and also, of course, where food is, in theory, more easily available. Yeah, people live hand to mouth. In Uganda, most people, unlike the president. Right. The other thing I think that's clear is there are public-private dynamics. So one thing that has been very clear is people working throughout the private sector in Uganda, whether that's formal or informal, have essentially lost all of their wages during the lockdown. So there's been quite a rebalancing of power relations around those that are in the public sector. So a school teacher in a public government school would be getting salary throughout the lockdown. In a private school, they would not. Yeah. So this has implications for older people in terms of older people, those that have the possibility of work in public office, those that have the possibility of receiving pensions. Yeah. So there are the ways I think the coronavirus has sort of recalibrated dependencies in Uganda. Yeah. The informal economy has been hard hit by the collapse in transport, yeah, and early inflation. So originally at the beginning of the lockdown, prices went sky high, but because of the transport collapse, at least in rural areas, there's been a collapse in markets for goods. Yeah. The other thing to sort of say at Uganda is all of this plays into political dynamics. Next year is a presidential election year. So Museveni, who's on that top photograph, will be standing for election again. And he has used this situation, I think, to sort of advocate his position as protector of the people. He's also at the same time been open to ridicule by some people for some of his statements. I think recently he suggested that every village should have 2 televisions to carry online education for students. And of course, Uganda is not particularly electrified in rural areas. So that was something that was open to ridicule. And COVID-19, there was a nice blog by an epidemiologist in Uganda writing for Oxfam about the way money has been sort of allocated through these systems. Yeah, so there was a £600 million loan from the European Union for dealing with the effects of COVID-19. 100 million of that went straight to the State House, went straight to the president. So that is money that is not open to any form of public scrutiny. Yeah, so there's been a lot of debate in Uganda about that. All right, the next slide. So just to put some arms and legs on some of these ideas of what it's actually like to be an older person, and Peter very kindly asked me to put together a short report with Stella of the experience of living with coronavirus in Uganda. And as you can see, this is an older gentleman, Suleiman Odongo, who is 68 years old. And when Stella was talking to him, he said, people will die of corona even before they get corona. Yeah, so again, it's this argument about the lockdown. And as with older people in Uganda in general, Suleiman is involved in a series of very complex interdependent relationships. He has a younger wife who goes to another part of Uganda to collect charcoal for sale in the urban center in which he lives. He lives in a household with many dependents, and it's through that business that they are supported. Oh, sorry, there's an ice cream van in the street, if you might hear that now. One thing he said, and perhaps that's something that can feed into the discussion later on, and it's a thing Ugandans will often articulate, is in this quote: I tell you the lockdown is not good, it will make you panic. Things are so uncertain, we don't know how long it will be for. It is not easy to survive at all. Most of us are poor and in town we struggle for food. People will die. And it's that last sentence that I think perhaps we can think about discussing, which is that there's a strong case that Ugandans would make that the measures to deal with coronavirus will result in death. And I think what Suleiman is saying is, he's not saying you will walk into the street and see somebody fall over. Yeah. But the effects of the measures to deal with one particular type of illness in Uganda has had a series of consequences for older people and for other at-risk groups. There was a report out by Open Democracy on the collapse of testing services for sex workers in Uganda who have HIV. Yeah, so you can see how the lockdown has really affected parts of civil society and parts of the public health sector that have been, dealing with people with other forms of ill health. Yeah, and Suleiman, like many people in his situation, has been avoiding the public hospitals through the lockdown, and he uses a private nearby clinic. And that's typical of the informal provision of healthcare in Uganda for many older people. All right, so if we turn to the final slide. So I'm trying to go through this quickly to give my colleagues time to talk. So picking back to those earlier themes on rural, urban, public, private, government, opposition, those are perhaps three domains in which we can think about how COVID-19 intersects with old age. Yeah, so the flight to rural areas, which seems to be taking place. Apparently there are rumors that there will be another severe lockdown in Kampala. So at the moment, people are leaving Kampala and returning to the countryside. These are often younger people leaving Kampala, returning to older relatives in the countryside who are already facing stretched resources. Yeah. So older people are likely now to be hosting younger family members in rural areas that have left the cities. Yeah. Then there are public-private dynamics. We need to think about older people who have pensions and have government salaries. They will be placed in a very different relationship because of the lockdown than older people who don't have access to those resources. So older people in Uganda are always part of complex dependencies, and there will be consequences for people because of the economic measures and the lockdown measures the government take. Yeah. And the final point to make, I suppose, is just the general way Ugandans would talk about, the people Stella and I have spoken to about coronavirus, is people refract this experience, whereas I suspect in European societies or North America, this is something very new. Dealing with a crisis of this type is not particularly new to Ugandans. So they refract their responses through earlier responses to health crisis. So one of the things that's been happening as public transport has been relaxed in Uganda and people can use vehicles, you're meant to wear a mask. Yeah. But what are masks about in Uganda? Are they about public health? Well, for many Ugandans, masks are about the police fining you for not wearing a mask. So at least Stella was telling me yesterday in Mbale, you will see people wearing masks at traffic intersections, and you will see them wearing masks when they get on buses and when they get off buses. Yeah. So a lot of the ways in which people are making sense of the virus and the government measures to deal with it are based on older practices around how the state, for good or ill, sort of intervenes in their life. Yeah? And the types of fees you have to pay and bribes you have to pay if you want medical attention and so forth. Yeah. So those are some of the dynamics, I think, that are at play that shape a context where the disease itself is not prevalent, but there are many externalities that come from the government response to that crisis. So those were the sort of things I wanted to put forward. And as I said, I'm not an expert on this, and neither is Stella, so we're just putting some things forward. And I know later presenters will have more sort of nuanced things to say. But Lucas, if you could jump to the final slide. So the final slide just lists some blogs we found interesting for you to read. LSE has run a series of blogs on the epidemic in Uganda. There's a nice piece, as I said, by this medic from Uganda reflecting on the political economy of aid around coronavirus and how that plays out within existing state structures. And then there's a nice piece in Open Democracy looking at the effect of the virus on sex workers, another vulnerable group. Thanks again for the opportunity, and I'll do my best to answer questions from a non-expert position. Great.
Thank you very much, Ben. Just before you go, can I check? I understood you said you needed to leave in half an hour at 3 p.m.
I needed to leave at 3 o'clock. Is that all right,
Yeah.
Max?
So because we're taking questions at the end, we won't be able to. You won't be around to answer the questions. But perhaps we could, if we could ask people to, if you have questions for Ben, please write them. Start writing them on the chat. If you click chat at the bottom of the Zoom window, then you could start putting through questions, and either we could pass them on to Ben to answer later, or we might be able to finish in time to take those questions.
Thanks very much, Matt. Thank you.
Right. So I'd like to go straight on to Dr. Wala Talat, who'll be talking about, was it going to be, oh yeah, so Wala next, we'll be talking about the experience of Egypt, older people, social protection, and COVID-19 in Egypt. So over to you, Wala. So Wala, if you can unmute your...
Thank you so much. Thank you, Max, so much. Thank you, Peter. It's my sincere pleasure, actually, to be invited to this great webinar and be part of the global platform for the rapid generation and transfer of knowledge on COVID-19 and older adults in low middle income countries. Well, actually, I've been working on social protection for a long time now. And before COVID-19, we were talking about the inefficiencies in the system. We were talking about how the government can reallocate the substantial amount of the resources and so forth. But after COVID-19, when it attacked everyone in every country, actually with no discrimination, that the gaps of the systems appeared upfront, and the countries saw the severe and massive gaps and how the COVID-19 really affected those who are at the most risk, who are the most vulnerable, actually, in each country. So it required the global collaboration. It required sharing the knowledge. It required the COVID-19 required all the countries to just share the knowledge and know-how and how to just contain this virus. But most importantly is we have to just think again and revisit again the social dimension or the social perspective. In terms of the inequality, in terms of the vulnerability, and who is the most vulnerable and who is the most at the risk, and how this contingency affected those segments in the country. So this would just impose the important question now: should we revisit again the international calls that been focusing on the systems of the social protection and how they do identify the most vulnerable, and if the programs is really now covered those who are the most at risk, or who is now fall into the trap after the COVID-19 of the poverty due to the inequalities and many more. So today my topic is older people, social protection, and COVID-19. Next, please, Lucas. Okay, giving you a quick, actually, demographic profile of Egypt. Well, the number of the population aged above 65 in Egypt is 5.3 million, which accounts for 4.6% of the total population. So we are talking about 5 million old people in Egypt. The Central Agency for Public Mobilization and Statistics, the CAPMAS, in 2019 showed that the life expectancy in Egypt is around 74 years, where 73 is for males and 75 for females. In Egypt, as in elsewhere, it is expected that the main burden of COVID-19 mortality will fall on the older people. And this is the main concern, actually, because the media in Egypt started to just say that most of the patients in the hospitals are those who are old people. And we knew that the coronavirus, or those who are most at the risk patients, are those who are old or above 60. Well, next. Then we can just, next slide, please. So this is the infection and the mortality report that is, this is a data tracker that the Ministry of the Health is daily reporting for the new cases. The first row is the new cases as of 10th of June, which reached 1,455, and the new death cases was 36. And the second row is the total confirmed cases, 38,284, and the total death cases are 1,345. So this is being provided, as I said, daily through the Ministry of Health and Population. However, it's worth noting that this providing incomplete picture, because the data is not disaggregated. As we see, we don't see who been affected, women or men, the number of women and men, what are the ages for the death cases, what are the ages for the confirmed cases. So this aggregated data doesn't show us the health disparities, I can say that. So it's important right now to acknowledge the pitfall. It's like, when we will acknowledge the pitfall if it's not now? So as we saw in Italy, for example, we saw all over the news that the people the death mortality was very high, but from the day one, they reported the disaggregated data. So this report can raise a lot of questions of why the Ministry of the Health and Population is not reporting the disaggregated data, which I would like think about, is the women are more likely to be diagnosed as a COVID-19 or not. I'm not sure about that from this data. There is any differences in men and women, sorry, risk of dying, which vary by age, or what factors may be driving differences in the illness and the deaths among men and women, and many more questions that this report actually doesn't show. And the Ministry of the Health and Population should reconsider giving the disaggregated data. Okay, next. Well, I try to just put the major actors now that could mitigate the potential effect of COVID-19, especially on the older people. So we have the Ministry of Social Solidarity. This ministry is the designated body that's mainly monitoring the aspects related to the older people. giving social safety net programs, enrolling them in those social safety net programs. And also it runs the social insurance programs and pensions, and the residential home care as well. It is responsible for running those residential home cares. And also the second actor is the civil society, how the civil society could mitigate the effects of the COVID-19, especially for the older people as well, from volunteering and the donation. And then the religious institutions, what is the role of the religious institutions in mitigating this pandemic? And finally, the Ministry of the Health and the population, how they run the isolation and the public hospitals and how the older people could face some of the risks, delivering medications. And finally, delivering medications, and finally using of the technology. Okay, next, please. So first, the Ministry of the Social Solidarity, one of the programs that has been promoted lately, actually, and it was financed from the World Bank with $400 million, is Takaful and Karama. Takaful means solidarity, and Karama means dignity. And Takaful is targeted, this is one of the major social protection program in Egypt nowadays. Takaful is targeted for the poorer families with the children under 18 in order to just encourage people to enroll the children and attend the school. And Karama is the dignity, and it's targeted for the older, the poorly older people, and also the orphans and household living with disabilities. So the disaggregation actually of this program by age in 2019 showed that 0.5% of the beneficiaries only are aged 65 that benefit from this program. And the low number of these people, maybe because the large majority of those people are receiving pensions, because this is targeted for the poor older people, or maybe because they are doesn't receive any, as I said, doesn't receive any pension, or they maybe are living with a larger households sharing their pension with. So in response to the COVID-19, the Ministry of Social Solidarity tried to increase this program vertically and horizontally by increasing the amount of the benefit itself from 350 Egyptian pounds to 950, and also increase the amount of the beneficiaries, the number of the beneficiaries been enrolled in social safety net program. The minister, she announced that there is more 100,000 families that are going to be enrolled in this program. Accounts for around 1 million individuals, but it doesn't say that how much families are above 65, or who will just receive this benefit, which is very important to say that when we respond to the COVID-19, it's very important to just know who fall or who been affected by the COVID-19. So the report must be actually provide this part of the data, and even the impact evaluation that's been implemented by IFPRI for this program. When I read this report, it said that we couldn't actually know the impact of the Karama, which is for the older people and people living with disabilities, and also the orphans. We couldn't actually know the impact because of the small sample size of the. So still until now, the effect of this program on the older people is somehow vague. Okay, next slide. So the second thing is, as I said, that the Ministry of Social Solidarity is running the social insurance or the pension, and that was great actually from the government. It implement a responsive, actually a good responsive measure when it run the social insurance after the COVID-19. The ministry announced the several proposals and scenarios for pensioners in order to reduce the COVID-19 by trying to arrange how the pensioners are going to pay to earn their pension. So it divided them to 3 categories actually, so that there will not be congestion or the congregation or overcrowding in the national social insurance offices or the post offices. So it divides them. One category who pay less than been earned less than 1,000 Egyptian pounds are going to visit the offices on 3 days, 3 specific days, the first of the month and the second and the fourth. And then the second category who are between 1,000 Egyptian pounds and less than 2,000, 3 another specific dates. And the last category, pensioners who earn more than 2,000 Egyptian pounds are going to visit the offices in 2 other days. And if anyone fall in these categories and not being paid for the pension, can just visit the office, the national social insurance offices or the post offices or the designated outlets anytime he would like after those dates. So the Ministry of Social Solidarity could run I would say, like, to a great extent successfully because they do acknowledge that there should be a distance between the pensioners, that they are old age and they are the most at the risk to be patient of COVID-19. So it could run there is 6.7 million pensioner in Egypt. So dividing them on 3 days, that was a great step from the government as well. There was in front of those offices and the post offices and the national social insurance offices, there was benches and there was a waiting areas and the chairs, as we can see in the picture. So that, and there is somehow distance. It's not 2 meters, but there is a distance, and there was a youth volunteering to distribute the face mask and sterilization in order as a precautionary measures for the pensioners. Moreover, the Ministry of Social Solidarity asked the Central Bank of Egypt to cancel any fees or any commission that could be applied on the withdrawal if a pensioner wants to withdraw his pension from the ATM other than visiting the office itself, which was a good step from the ministry. Okay, next, please. Okay, now the role of the civil society, and with COVID-19, the civil society has an important role actually in volunteering and the efforts with the state actually to fight the pandemic. We can see here that some of the NGOs try to take the patients of the COVID-19, especially the older age, and they promote for them facilities that could access to the private hospitals, and they pay the bills for the patient that cannot afford to pay in the private hospitals. And also some of the NGOs try to train some volunteers how to help the older people to put the masks for their hygiene, giving them some of the instructions while they are of the places that could be crowded. One of the major NGO is Risala in Egypt as well. It made a charity challenge and used the celebrities all over the media, and they collected more than 3 million Egyptian pounds in 1 week. And we have the Mercel as well, trying to find the beds for patients in the private hospitals. So, and from 3 days, I guess, the Egyptian Red Crescent had a collaboration with the Ministry of Social Solidarity and the Ministry of the Administration and Planning, trying to, they will donate 51 million and try to train volunteers and do a lot of the support for the Ministry of Social Solidarity and Ministry of Planning and Administrative. Okay, next.
Wala, could I just interrupt? Could you bring it to an end? If you could finish within a minute or so, please.
Yeah, sure. I'm going to the end now. So the religious institutions, they donate for 5 million for Al-Azhar Sharif, and the Coptic Orthodox Church also donate with 3 million in order to buy the ventilators for the hospitals. Okay, next. Next, please. The Ministry of the Health for the isolation public hospitals and the state university hospitals, all of them are opened, and now we are at the borderline, I can say that. The hospitals are congested and overcrowded now with patients, and the Ministry of Health tried now to just ask the private hospitals to be open. And here is the tension that the cost of the private hospitals, who will pay the bill and how much, because some of the bills reached from $800 to $1,000 per day. So who can pay for 10 days this amount of money? And in response for the complaints, the Ministry of Health and Population tried to deliver the medication to the patients at their home, especially for the old age. And it uses the technology, the application Sahat Masri, because of the complaints that the emergency number call doesn't respond, WhatsApp as well. So it made some of the contribution to actually using the technology because of the complaints. It was very responsive. Oh, okay, next. So we can say that the Egyptian government, state universities, to a great extent, and civil societies, religious institutions implement responsive measures to fight the coronavirus. However, the government didn't report the COVID-19 cases that's disaggregated by the age, which is the proper understanding of the age and the gender differences in terms of the incidence and the mortality is the first step to investigate the biological and investigate the social mechanism. It's very important now to underline the vision, where are the gaps exactly to improve in the future. Okay, last slide now. Going to the conclusion at the end is that solving the problems needs institutions, and the debates around whether to target or not the social, the main concern at the international cause, if we return to the international cause, its main concern is the universality. Everyone should be included, even the those who are at the most risk, who are the vulnerable. They should have this minimum floor of the access to the healthcare, the social protection for all of them, so that this COVID, this pandemic showed the gaps in the system, and we have to just reform the social protection toward the universality and including. And so the main agenda, I would say, one of the main agenda that should be put in Egypt especially is the social inclusion policy. And thank you so much for listening. Thank you.
Thank you very much, Wala. So just to remind people in the audience, if you can start, if you have questions for Wala, if you can start writing them into the chat. So say you click on the chat button at the bottom of the screen, and then we'll put those questions to her later. But right now, our speaker will be Sarah Edgar from Save Elders in Tanzania, talking about the situation, particularly about the role of NGOs in protecting older people in Tanzania. So go ahead, Sarah.
Thank you very much. Again, my name is Sarah Edgar Lamba, and I'm the founder of an organization called Smart Youth Effort for Advanced Community. And for almost like 3 to 4 years, we are running a program called Save Elders Tanzania. It's a young people organization aiming on improving the life of older people in Tanzania. So before COVID-19, actually, we had our EL plan, and we are much based on supporting older people and issues of hygiene, nutrition, existing new ventures like business and etc. But after COVID-19, we have rescheduled some of our plans and activity. And so far, here is the role of NGO in protecting older people during COVID-19 pandemic in Sub-Saharan Africa. Next slide, please. So we have different activities so far, but on the introduction part, as I said before, we are young people aiming on improving the life of other people in Tanzania, and we envision on the world that everyone gets equal chances to participate, to make decisions, and to live. COVID-19 in Tanzania, we had no such a really like strictly lockdown, because for now life is just running like it was, and we had like few days lockdown, but we had less cases recently, and I think the government it allow us to proceed with the normal life that we had. So what drives us to respond as an NGO? So we had some social media trending meme that show some of the older people, they don't know how to dress their face mask. And we had we just heard from WHO, like older people are in a high risk to get COVID-19. And because we're younger people, we are getting quick information. So we think it was a right time for us to make sure that we are helping older people who are not that easily getting the information because they are not much on technology. Next slide, please. So as organization, as an NGO, we have played different role, but specifically we had four, not three huge role. One, we published some online learning classes, learning material where younger people, the volunteer or younger people from Tanzania learn about COVID-19, its origin, and its cause, effect, and the symptoms itself. So number of 56 younger people get knowledge about COVID-19. Some are members of Sevilda and some are just not members of Sevilda. But we had a call to update to older people, because recently we, for the older people that we are working with, some of them, they have access to mobile phone, just normal mobile phone. So as we were waiting for the government to say, like, it was a really lockdown, we're not like allowed to go out, we're just expecting that. So we proposed to have a call to update, whereby we start to call some of our beneficiaries, older people, and inform them about COVID-19. So 20 young people joined the campaign. It was an online campaign, and number of 20 older people being reached with information about COVID-19.
Sarah, I'm afraid we can't hear you. I wonder, could you try turning off your video? That might help.
Okay.
That's clear, thank you.
Can you hear me?
Yes, we hear you clearly, thank you. So go ahead.
So can I repeat, or it's okay?
Hi, Sarah. If you just start the text that you were going to give for this particular slide that you're displaying at the moment about face masks, that'll be fine.
Okay, thank you. So as an NGO, the third thing that we are just, we work on educating and capacitating older people on face mask and proper hand washing. And this was a training whereby younger people just mobilize older people around different places in Tanzania and capacitate them on how to wear this face mask. And also because they know how to wash their hands, but not everybody knows how to wash properly their hands. So we were there to capacitate them on hand washing too. So this, it was, we were able to mobilize number of 40 old people and being trained in Ruvuma and Dar es Salaam, and number of 10 young people become trainers, like they facilitate the training. But our last not least activity, we are able to capacitate older people on issues of nutrition, because during COVID-19, we just get information that older people, because they have less nutrients, maybe is the reason why they are mostly like to be affected by the COVID-19. So as the organization, we thought maybe training them about proper nutrition based on the food that are local available is going to be a hopeful hand for them to be able to maintain their nutrition or their food diet. So number of 10 older people being trained and number of 7 younger people facilitate the training. Next, please. Okay, so far, that's how we respond to COVID-19. So we are looking forward to have more activity in the next 2-3 weeks, next 2-3 weeks ahead. But so far in Tanzania, I think the things are working properly now. We have no any lockdown. So I'm not sure if you are going to train more about COVID-19 or we're going to train them about emergency response. So we're still thinking about this because we have no cases about COVID-19. That's all. Thank you.
Right, thank you very much, Wala. So that was a really good overview on what's been happening in Tanzania. So you've been fortunate to have very few cases, but seemingly well prepared if the epidemic goes on for a longer period. So just to remind you all in the audience, please, if you could start putting questions to Wala and also to Sarah and to Wala before that, if you can start putting questions in the chat, and then we'll start putting those questions to them, which I'll do from the chair. Peter asked me to say a few words about the epidemic in South Africa. So I hadn't prepared anything, but I'll make a few comments, particularly in relation to older people. So as Peter said, in South Africa, probably like Egypt, has one of the largest epidemics in Africa, with to date about 56,000 cases tested positive, but of course that's just the tip of the iceberg given a limited extent of testing, and there've been about 1,200 deaths. The numbers of new cases per day are starting to go down, and most of the cases, almost 80% of all the cases and deaths have been in the Western Cape province of South Africa. It's down in the southwest, and almost all of them have been in the city of Cape Town in surrounding area. So very concentrated epidemic still. So suggesting it could possibly expand to the other parts of the country later. But South Africa had a very strict lockdown, which was enforced by the military and the police quite brutally at times. Over 240,000 people were arrested for breaching lockdown regulations. At least 8 people have been killed by the military and police in enforcing those. And although now that the numbers of new cases are starting to go down, South Africa has gone into the second stage of easing the lockdown regulations. So people are allowed out for limited periods every day, but still greatly affecting the whole population. And it's raised a lot of debate within South Africa, but it's obviously relevant to the rest of Africa, is how strict the lockdown and related disease control measures should be, given the bad effects they have on people who are struggling to survive anyway, people on low incomes, people in informal sector employment, and in the face of the relatively limited, relatively small epidemics, relatively small number of deaths. So that is a big open question still being debated. With regard to COVID and older people in in South Africa. As I said, more than 80% of the deaths have been in people over 50 years of age and older, even though they make up a relatively small part of the number of people infected. And as in Europe, UK, North America, the biggest determinant of whether you survive or die when you have a COVID infection seems to be whether your age, and in particular, whether you have another chronic disease, another non-communicable disease. So I mean, South Africa has very high prevalence of hypertension and fairly high prevalence of diabetes, which is largely related to the very high prevalence of obesity, even in rural areas. And in the Western Cape, where most deaths have been, half of the people who've died also have diabetes. So this is just highlighting the importance of the chronic diseases, of aging, of obesity, in influencing the effect of COVID on people's survival and deaths. One of the things that's particularly important to South Africa is, a big question has been whether HIV infection and tuberculosis, both of which are very common in South Africa. South Africa has the largest number of people with HIV in the world of any country. So there was a big question whether that would affect people's survival or death if they did get COVID infection. We don't have good data on that yet, but it does seem preliminary data suggests that actually if people do have HIV, but the HIV is well controlled, if they're on antiretroviral treatment, they are not at greater risk of death than people without HIV. And it also seems that people with tuberculosis on TB treatment are not at an increased risk of death. So with relation to why that's relevant to age is bear in mind that most people with HIV are younger people, whereas most people with chronic non-communicable diseases are older people. So it's just highlighting, whereas while everyone is at risk of COVID, it's particularly those who are older and with non-communicable diseases that are dying. And so one of the many responses to the epidemic, but a big concern has been how to manage people with chronic illnesses going to primary healthcare clinics, where they're very crowded, large numbers of elderly people susceptible at risk of infecting each other. And there has been this question about whether it's actually safe for people to go and get their treatments for chronic diseases, or whether they're not putting themselves at greater risk. The South African government has tried to a large extent to make it less necessary for people to go for regular visits to their clinics by providing up to 4 months of medication at a time. And some of these clinics, the large clinics in the Western Cape, have tried to reorganize themselves so as to put in distancing measures so people aren't all standing on top of each other. So those are all some of the questions that, some of the examples that have been coming from South Africa. So the number of deaths and infections is going down, but it could still take off again. So that's all from South Africa, and you're welcome to put questions to me in the chat as well. So what I'm going to do now is to go over to the chat box on the right here and see, put some of the questions, which I'll read out. We're not going to ask members of the audience or people asking questions to speak themselves, just because of the complications of muting and unmuting the microphones. But I'll take a first question from, where were we? Oh yeah, so perhaps the first question comes from Peter asking Wala about the situation in Egypt, saying, Wala, do you know if some parts of Egypt have been harder hit than others? So over to you, Wala. And can you unmute?
Yes, actually, Cairo have been the capital actually, and we Cairo and Giza, and we call it like this is Greater Cairo, have the most confirmed cases around 1,000 from those two governorate, and then this is very good because we are not seeing that in the rural areas, and those who maybe it will be very hard for them to have this access like those who are in Cairo or the Greater Cairo. So the coronavirus is in the mainly the patients are in the capital city.
Okay, thank you. Thank you, Wala. So we'll go on to another question just to keep moving. So Peter also asked Sarah, I think you've answered but in writing, but Sarah, for the rest benefit of everyone else, Peter asked, has responding to COVID-19 reduced your scope for older people, your scope to older people of other issues? Are you less able to deal with other issues in older people in Tanzania? So Sarah, if you could unmute, if you could answer that. Sarah, yes.
Thank you. I would love to respond to the question about where has the responding to COVID-19 reduced the scope? No, in our case, it didn't less our scope rather than widen out, because as an organization, we had this plan before. We had a plan to capacitate older people on issues of hygiene. So as we respond to COVID-19, it didn't lessen our scope rather than widen out, because we reached a huge number of older people during this time of COVID-19 rather than before.
And perhaps I could just squeeze it. Do you think that this is COVID-19 and your response there has given you opportunity to do other things, or has it given you access to working with older people that you didn't have before, perhaps? I mean, has there been opportunity created by this crisis?
Pardon?
No, I was saying, has the work you've been doing with older people on COVID made it possible to actually do other work? Has it given you opportunities for more contact with older people? Well, sorry if that's not clear. That wasn't a real a crucial question. It's just following on from Peter's question. So we'll go on to other comments here. So there's a comment from Paulette Metang, just a comment to all panelists, not asking questions, saying much appreciating to the younger generation for all the older work on older people in Tanzania. So now we go on to a question from Cara Shepherd to Sarah. So Sarah, what has the opinion been of people in Tanzania in relation to the threat of coronavirus, especially given the very different approach taken by the Tanzanian government? And do you notice a difference of opinion across the generations, how the government has responded?
Okay, thank you. As I'm going to respond to the question, for the case of Tanzania, I just noticed like most of younger people like us, we were not really okay with issues of lockdown. So I'm saying this because I remember what happened on our side. They closed the university, they shut down the university and secondary schools and schools at all. So we just had like students say like, we miss to go back to school, and others, they even complain, why did we do this? So the day when they announced like we are just opening back the schools and the university, and everyone was happy, especially younger people. So I noticed that what government is trying to do, like no lockdown and people, they should run like it was before, it's the right decision, because younger people like me, they still want to they just want to proceed with their normal life, like going to schools and etc.
So you're saying, Sarah, that most people are actually quite happy that their lives haven't been disruptive. So they're pleased that the government hasn't imposed a lockdown.
Yes.
Yeah. Okay, thank you, Sarah. So there's another question to Sarah from Nifa Isalano, and if I can just, the question's not entirely clear to me, Nifa. So it's saying, I think partly the first is asking about your president's response and praying to God, and then Nifa also has a question, how many people have died? I think Peter said at the beginning that there were we don't know of any COVID deaths in Tanzania. Do you know anything more about that?
I think we had the response. I think Lucas displayed the first page with some of the statistics on how many just lost their life because of COVID. But
yes,
concerning praying to God and the medications, the treatments, the herbals, I think they're working here. So yeah, and the good thing, older people, they're the good users of that. The older people, they're the good users of herbals. So yeah, so we are still on. We didn't prove it, but that's how. But we also have beliefs, so we pray to God and try to use other ways and see. But so far it went well because we have no any cases.
Okay, thanks, Sarah. And I've just gone back to the slides just to check that what Peter presented originally, saying, as far as we know, there've only been 509 confirmed cases in Tanzania with 21 deaths. But just commenting that that might not be accurate if there's been very little testing been going on. So, right, okay. So Catherine saying, Catherine Klein commented there have been 21 confirmed deaths. So we don't have any more questions as far as I can see. Does anyone else have any further questions to our panelists? I don't. So I think we're coming to the end. So before we thank our panelists, I just want to check with Peter. Peter, is that, should we draw to an end here, or do you want to make any comments?
Just a couple of things, really. And firstly, a massive thanks to you, Max, and to our other participants. And I think this has shown that clearly there's a lot to think about in terms of coronavirus and older people in all parts of Africa, including those parts of the continent, such as Egypt and South Africa, where the pandemic may be concentrated in certain large cities, but it looks like it's really starting to hit very hard. But also in those parts of the region where, to date, thankfully, the direct effects have been limited, but we've seen some of those more indirect effects, particularly of lockdown. And very little is being done to focus on the specific vulnerabilities of older people in the region. A couple of quick points, I think. One of them is, and this is something that Max raised and Ben touched on as well, is potentially one of the largest effects of older people on older people, I think, will be their reduced access to health services for chronic conditions. Non-communicable diseases like heart disease, diabetes, and stroke are the leading causes of illness and death among older Africans. And these are conditions that require regular interaction with healthcare providers. Of course, many older Africans don't get that kind of access at the best of times, but one can only imagine the impossibility they have in terms of getting regular treatment for these conditions over the last few months. And it will be interesting, if that's the right word, to observe increases in overall mortality in the older population when hopefully those data become available and hopefully those data are robust enough to permit analysis. One other just quick point, we posted on the global platform, I think yesterday, some very interesting guidelines that have been produced by Tear Fund, which is an NGO which works very closely with religious organizations, looking at the role of religious organizations particularly in sub-Saharan Africa. And I think that links into some of the points that Walla made about religious organizations in Egypt. And I know this is an area that Ben has done a lot of work on in the past. And of course, also we heard from Site Savers to some degree about the role of church and other religious organizations. And I just wondered if anybody just wanted to make any final comments, any of the panelists, about the specific role of religious organizations. Where do they fit into this jigsaw of responses?
So Wala and Sarah, could you comment on religious organizations in Egypt and in Tanzania? I think Wala, you did specifically speak about religious organizations.
Yeah, thanks so much for this question. The religious organizations, actually, there is a long history actually about the religious organization, especially when there is contingency and how to support people, especially those who are, I would say, like those who are vulnerable or those who are not covered through the social protection, or those who need support. So the religious institutions come to just donate, because we do have lots of things. It depends actually if you are Muslim or you are Christian. For the Islam, we do have the system of zakat, which is you have to just take some of your money out for the poor and give it back to the institutions in order to support. This is another thing, to support those who are poor, those who needs help. It depends on the situation, the current situation. So we can say that this is a kind of like safety net that could help in the contingencies. And as I said and mentioned, that the once this happened, the two pillars, actually, the Azhar Sharif and the Coptic Church in Alexandria, both of them directly donated to purchase the ventilators in response actually to what was happening in the world, not because we do have a crisis at that moment, because what was happening in Italy and Spain. And so we were like trying to purchase the ventilators before the outrage or the to be out of control would happen. So they try to equip the hospitals with these ventilators. So somehow they are trying to support. It can be the role of the religious institutions is to support like a safety net. I would say, like I would put it like this is somehow safety net and somehow trust now, because when I'm just giving the money to these religious institutions, I'm sure that it will be just come out when there is a big contingency like this.
Okay, thanks very much, Walad. And Sarah, do you have anything to add about role of religious organizations in Tanzania? Obviously, you have Christian and Muslim communities in Tanzania. Any comments there?
Actually, the last speakers had my words already. So maybe in additional, I think let everyone play effective role to make sure that the equal society that we're looking forward to have, and we should make sure that every older people, they get information. Because I remember when I called my grandmom and asked, did you heard about COVID-19? And she told me like, yes. And I asked like, where? And she said like in the church. So everyone should be very smart on sharing the information. Thank you very much.
Okay, thank you very much, Sarah. And so Peter, back to you if you want to wrap up.
Thank you, everybody, and thank you very much to Max. I would just like to, excuse me one second. Yeah, that's better. I'd just like to point towards hopefully some of our future webinars. In 2 weeks' time, we'll be having a webinar on care homes and coronavirus in low and middle income countries. We did have a webinar focusing on this topic about 6 weeks ago. Clearly, a lot's gone on since then. And we want to update on the situation, particularly in Latin America, where we're expecting to have a speaker, one of the people responsible for government policy for care homes in the whole of Mexico City, and also somebody who's a representative of the Argentine Society of care home providers. So I think we'll get some very interesting perspectives there. If anybody is interested in submitting a paper for a future webinar or even a topic for a future webinar, they can go to the website, which is here on this PowerPoint, and let us know about their interests, and we'd be very happy to support you with that. So that's all we've got to say. Final slide, please. I'd just like to thank very much Lucas and Harsh, as well as, of course, Max and all the people who gave the presentations today. I'd also like to thank the University of East Anglia, which is providing a small amount of funding to support these activities. Stay safe, stay well, and I hope to see you in our next webinar. Goodbye.
Bye, thank you.
Bye.
Goodbye.
Bye, everyone.